Hello, very good evening to you. Many thanks for joining us here for another edition of Moomen Tonight. We're coming to you live on GBC 24. My name is Abdul Haji Moomen, and tonight we take a look at the National Health Insurance Scheme, and we ask the question, is the National Health Insurance Scheme poor? You know, the St. Ghana NGO has put together a report that seeks to address this problem. It seeks to find answers to this question: is the National Health Insurance Scheme poor? Tonight, we also seek answers to this question, because the National Health Insurance Authority was established under the National Health Insurance Act 2003, Act 650, to consolidate the work of the authority. A new law, National Health Insurance Scheme, NHIS Act 852, was passed in 2012 to replace Act 650. As part of its mandate, the NHIS is to make healthcare accessible to persons covered by the scheme. Central to provision of basic healthcare services is the poor and vulnerable in society. And we are asking, how accessible is the National Health Insurance Scheme? And with me in the studio are two gentlemen and a lady who will be helping me to find answers to the question, is the National Health Insurance Scheme poor? With me to my immediate left, and they say ladies first, so I'll introduce a lady here first. Adwoa Twum. Adwoa Twum is the Senior Manager, Research, Policy, Monitoring and Evaluation at the National Health Insurance Authority. Adwoa, thank you very much for accepting our invitation. We are glad that you made it. Next to Adwoa is Mr. Frank Torblu. He is the Executive Director of Health Insurance Service Providers Association. Always glad seeing you and talking to you. This is not the first time he is appearing on our screens. We are grateful that once again you were able to make it here. We also have Mr. Adamu Mukaila. He is the Program Officer at St. Ghana. Mr. Mukaila, nice to meet you, and thanks for accepting our invitation. Now, I'm just, because you are from St. Ghana, and it was you that put together this report, because the central theme seeks to be the poor, poor. Yeah. And whenever you use terms like rich and poor, these are very subjective terms depending on one's location at a particular time. Yeah. In this context, who do you define as being a poor person?
Thank you very much. We actually looked at the definition given by Ghana Statistical Service, which actually is based on consumption expenditure. Yes. So according to Ghana Statistical Service, if somebody earns below 792 Ghana cedis a year, then that person is considered as poor, extreme poor. You are poor when you spend 1,314 Ghana cedis. So that is the upper limit of poverty, and then the lower limit.
You're poor when you spend, I'd like to get 314 cedis a year. Oh, this is a year.
A year. Mm. That is, you are considered as poor. But if yours is below 792, then you are considered as extreme poor. What it means is that if you use all your income and you decide to spend that income on food, you will not be able to meet your daily food requirements. That is the extreme poor cases. But the poor, they will be able to meet their daily requirement, and they can't do any other thing apart from food. So that's what it means, okay, according to the Ghana Statistical Service definition of who the poor is.
Now that we have contextualized the definition of poor, I'll come to you later on, but let me turn my attention now to Mr. Torblu. You represent the Health Insurance Service Providers Association. Sure. There are many people out there who are still unaware that apart from the National Health Insurance Authority and what they provide, that there are others out there. Who are they?
In terms of
your existence, I mean, what other, if for instance, I do not have access to the National Health Insurance, or I don't like the services provided by the NHIA, are there any other alternatives?
Oh, okay. Yes, there are about almost 16 to 18 of them in existence. So we have other health insurance schemes in the country.
And how differently do you operate from the National Health Insurance Authority?
If I may not be taking the issue out of context, I represent the hospitals, not
the hospitals.
Yes, the healthcare service providers, not the private health insurance.
Okay, okay.
So
Thank you very much for that, because I was actually under the impression that you represent the insurers rather, and not.
No.
Oh, great. So, but
the hospitals.
The hospitals.
Yes.
But then it means that you at every point in time have to deal with all these 16 groups that you've just mentioned, including the National Health Insurance Scheme.
Exactly.
Okay, interesting. So that means that I can ask you,
sure,
how effective are the services of all these groups, including the National Health Insurance Scheme?
By and large, National Health Insurance Scheme as an institution, I mean, mandated by the laws that put it up, appear to be the best of all, I must confess. Even though in the private sector, there are a whole lot of issues that you can talk about, especially when you come to looking at the cost involved in getting onto the private health insurance scheme as against the National Health Insurance Scheme. You will agree with me that National Health Insurance Scheme is a social policy intervention. So therefore, they are more geared towards getting people who are unable to meet their daily requirement, as my gentleman has just put it, to come on board as a way of removing poverty among the ordinary Ghanaians. But then if you go to the private sector, you will agree with me that they are people who are in the upper class and the middle class and have so much to spend and would want to have a different health scheme that will enable them take care of their health needs at any point in time. So in that case, when you look at the private health insurance scheme, they sometimes even allow certain medications that are not allowed under the National Health Insurance Scheme. For example, the National Health Insurance Scheme go for generic products, whilst the private health insurance sometimes go for both generic and branded products. So these are the differences that exist between the two.
And thanks for that correction there, because I would have then started off from a very different tangent. Adwoa, you are directly working with the NHIA, really, since your establishment. I understand about 2005 or so, 2004?
The law was passed in 2003 and implemented in
2004. It appears every year we hear about negative things happening within the NHIA and the service provision, especially when it comes to the payment of health service providers, and then again when it comes to even the delivery of medication to patients. How bad is the situation?
First of all, the NHIS is not the one that delivers the medicines. The NHIS has, so the NHIS is mandated to pay for the services that are provided. So we are a health purchaser, and the hospitals and the clinics provide the service. So the medicines and the services come from the health providers, and the NHIS pays for those services that they provide to NHIS clients. One of the biggest bottlenecks in the NHIS is the payment of the claims. Sometimes claims payments to the providers delays, and it's mostly from the bottlenecks of the funds to the NHIL from the consolidated fund. So those are some of the issues that NHIS have when it comes to paying claims on time.
And well, I wouldn't want to push you into the politics. Otherwise, I would have asked, how come that? And I'm not asking you to answer, but I'm just wondering why it is that we have an NHIL, and every time I purchase something, there's money that goes into that account.
Yes.
And so it is meant to have money all the time, and yet all the time the NHIS appears never to have money. But let's turn our attention to the main reason why we're having this conversation, which has got to do with the report about whether or not the NHIS is pro-poor. Why that report? What was the motivation for beginning to put that together in the first place?
Thank you very much. The NHIS, as you indicated, was established in 2004. So in 2010, SEN decided to do assessment of the policy to see how the policy is going. In that report, we came out with a lot of funding. We actually recognized the fact that the NHIS came to increase access to healthcare, especially OPD attendance. At the same time, it also exposes the challenges, the general weakness in our health delivery system. As more people attend, there were no doctors and nurses to attend to them. So those issues actually came out. And normally when SEN undertakes a survey, we just don't end it when we publish the findings. We go a step further to engage stakeholders with our findings. So we did 30 engagement in 30 districts. And one of the issues that came out strongly was the issue of these poor. People were complaining that they are not benefiting, especially the poor. So this survey was actually informed by the issues that came out during our last engagement with our last report. So we decided that if that is the case, if people are saying they are not benefiting from the national health insurance, especially the poor, the PWD and the marginalized, then why can't we even look at the national health insurance and look at who are on the list, the NHIS subscribers? Who are they? Are they the very poor that the policy is targeting, or different people? So that informs us in our next research, and that's the more reason why we did this research.
And maybe I'll jump over Mr. Torblu and come back to you, Adwoa. Dealing directly with patients, do you sometimes get a feeling that you are not dealing with poor people, and that those you are dealing with are maybe from the middle class to the upper?
Well, the SEN Ghana report obviously adds to a lot of the research which is already out there, that the NHIS is inadvertently targeting most of the middle class rather than the very poor people in Ghana. And recently, NHIS itself, in collaboration with some development partners, did a study, and it was confirmed. We wanted to find out why is the NHIS targeting more? I mean, what are the barriers to enrollment onto the NHIS? And a lot of issues came up. Some of the barriers that people mentioned was distance to the scheme offices and distance to the hospitals themselves. Some mentioned other barriers, including the roads that they have to travel, not distance per se, but other barriers that, for example, some people live in areas where they have to cross the stream before they even get to the provider level. So all those things are barriers for people to enroll on the NHIS. So when we look at it, people who live in far to reach areas are more likely not to enroll on the NHIS because they think, if I even enroll, I don't have access to the health services itself, or it's difficult for me to access the health services itself. So what is the point of enrolling? So I think those are some of the reasons why the NHIS seems to be targeting more people, or reaching more people in the middle class and in the urban centers.
Mr. Torblu, what's your observation, having been someone who works directly with the health service providers? Do you see more people coming in, and do you identify such people as those higher up there, or you see them to be the very poor people who really are the targets of the National Health Insurance Scheme?
Sorry. Presently, what we are seeing is we're seeing people of middle and upper class the more. And one challenge that I've also observed, as far as the law is concerned, is that the definition of the poor, makes it a little bit difficult to get people onto the scheme. Because if you closely look at how poor person is defined under the National Health Insurance Act, you realize that if you're not careful, you end up not getting anybody to register as, poor by that definition. So I think that
maybe it will be interesting if you can tell us exactly what it is that bars people from being captured because of that definition.
I think my senior research person should be able to define that properly.
Because
he has an in-depth knowledge.
Right. No, but I thought you could give us from the
for instance, if
provider's point of view.
Yeah, from the provider's point of view, when they talk, let me even start from the legal point of view, how it is defined in the law. It's talking about somebody who cannot even have, who does not have a permanent place of residence as poor. And today in Ghana, everybody seems to have a permanent place of residence in one way or the other. If you're not living with your brother, you might be living with your cousin. Definitely, you sleep somewhere. So that is a difficulty. Probably that person might seriously be poor in any way, but because of that definition, is obviously getting out of that. That is one aspect of it. But then, if you are at the hospital level, you see people coming. You will see that poverty is actually telling on somebody coming to your hospital, but how many people? You understand? The number is not as compared to people of a middle and upper class coming to the hospital. You definitely see that. You understand?
You were about to explain to us further what's in that context as well.
Yeah, like he's saying, we have the national definition of who is poor, which I've just explained, the Ghana statistical one. And the NHIS also have their own definition of who is poor. For instance, the person should be unemployed and do not even have any identifiable source of income. That is one condition. 2, he shouldn't have a permanent place of abode. 3, he should not be staying with somebody who have income, who have a fixed income, or who have a permanent place of abode. And 4, he shouldn't have any recognizable support coming from somewhere to him. So when you put all these 4 things together, then it becomes very difficult to just pinpoint one person and say, yeah, this person meets all the 4 criteria, and therefore we should enroll that person into the national health insurance as well.
On a light note, per that definition, I must be a very rich man then, because
you are.
Yes, once you have a recognizable source of income,
yes, then I have a place of abode.
You have a permanent place of abode.
I'm a very rich person then.
Rich.
I mean, okay, but getting back to the serious business, I'll still be with you a while longer. So, how many, I don't know if your research was able to capture what percentage of people fall within this category as defined by the NHIA law?
Yeah, those defined by Ghana Statistical Service actually indicate that if you take the extreme poor, those who find difficult to even feed themselves, they are about 2.2 million. That is 8.4% of Ghanaian population. That is those who cannot even feed themselves. And those who can just feed themselves and nothing else, those we call the poor, they are about 6.4 million. And if you take the upper west where I'm coming from...
And that's what in percentage terms, do you remember?
Yeah, that is 24.2%. Yeah.
Okay.
You take the region that I'm coming from, upper west region. If you look at the extreme poor, they are about 45% of the total population. The NHIS has been able to register 14% of that population, leaving 31%. These are people who can even not meet their daily requirement if they to spend all their income on food alone. So it means that 31% of them are out. So these are the people that we want the NHIS to work with Ghana Statistical Service to identify. If their definition is giving us problem, why not just leave it somewhere and look at this definition, which can easily point out people who are very poor so that we can register these people.
So forgive my ignorance, and this I'm throwing to all 3 of us here. How does the definition of whether or not I'm poor stop me from accessing healthcare through the NHIS, for instance? I don't get it.
Yeah, because
yes, Mr. Frank.
Yeah, the issue has to do with payment of premium. You understand? When you are classified as poor, obviously you are not going to pay premium. That is the issue here. So it is only when you go through the normal process to be classified as poor. In that case, the premium that is supposed to be paid would be taken off you. So you become an exempt category person, sort of, to the extent that you will not be able to be asked to pay premium to the National Health Insurance Scheme. So that is the difficulty there. So to be able to identify who is actually poor has to do with payment of premium. So that is the preventive factor.
So Adwoa, when you are identified as being poor, per the definition of the National Health Insurance Authority, then you have access to healthcare, but you don't pay a premium.
You don't pay a premium.
Exactly.
Okay.
So it's free.
So then,
indigents.
Again, if I'm being too hard, forgive me, but it appears as though that definition was given so as to be able to get more people away as possible.
You mean the definition?
The definition of who a poor person is, so that we exclude so many people. At the end of the day, the burden on the Health Insurance Authority will be very little. Is that it?
Well, the NHIS population, almost 70% are exempt from paying any premiums. Pregnant women are exempt. All children under 18 years old are exempt from paying any premium, and indigents as well. All SNIT contributors are exempt from paying any premium, and all people over 70 years old are also exempt from paying any premiums. So really, the bulk of the premiums is supposed to be paid by the people classified under the informal sector. So it absolutely was not done to turn people away, because majority of the people of Ghana who would register on the NHIS are already exempt from paying any premiums. But the challenge with the NHIS has been, so we know that we have indigents per Ghana Statistical Service surveys, but who are these people? Where do we find them? How do we find them so that we target them for them to register on the NHIS?
The premium, is it the same amount across the board?
Well, in the law, the premium is supposed to be staggered according to your ability to pay. So supposedly a richer person is supposed to pay more than a poorer person. But in our situation where we don't report our incomes, especially outside of the formal sector, we don't report our incomes, we don't report our assets. Those are difficult to measure. So it's extremely difficult for somebody to walk into the scheme office and by you not having access to what their income is, what their expenditure is, deciding that, okay, you pay the full 48 cedis or you pay nothing at all. So those have been some of the challenges.
Now you have biometric registration process and all. Don't you ask questions such as occupation and so on and so forth?
We ask those questions.
Are those not indicators as to whether the person is poor or not?
Definitely, those are. So those are some of the things that we've been using to register some people. And the NHIS has also worked together. There's a livelihood empowerment against poverty program run by the social welfare department. So NHIS collaborates with those. Everybody who's registered under LEAP is considered an indigent, and then registered under NHIS doesn't pay any premium. So those things, those mechanisms are already in place to find some of these people, identify them and enroll them. But it's obviously not sufficient to get all of them.
What's the minimum amount for premium as we speak?
0 cedis, and then after that is 7 cedis.
I like that, 0. That was a smart one. So the next one is 7 cedis. So again, turning my attention to you, Adamu, are you saying that some people are so poor that they cannot afford the 7 cedis premium for a year?
Exactly.
In Ghana?
Yes.
Tell me about
Extreme
it.
poor.
Tell me about
Like
it.
I said, there are 2.2 million Ghanaians
Who cannot afford
Yes.
7 cedis?
a day. They cannot even afford, let me put it, $1 a day.
No, $1 is
That's
4 cedis,
4 cedis.
approximately.
So you are talking about 7 cedis, which is even more than $1.
But this is 7 cedis for a year
Yeah.
to take care of your health needs.
There are people like that who cannot pay that amount. Because if you consider, if the person has to even spend 4 cedis every day and he's not getting that money to spend, what is he going to eat and take the 7 cedis out of it and go and register? So that is the situation. They are too poor to the extent that if you don't do something about it, and that is the more reason why you see the government coming out with this LEAP program, so that they can be giving something to also help them.
Yes, again, Adam, forgive me. Maybe I'm... But so let's get back to this category of poor people.
Yeah.
And I, working as a journalist,
Yeah.
have encountered families
Yeah.
that told me and actually saw the kind of food they were eating.
Yeah.
There was no protein, there was no meat in the soup, and it was just a bowl of tuzafi. However, the head of the home had a ranch, cattle.
Yeah.
And yet they were eating poorly in the house.
Yeah.
Such a person said he was poor, he had cattle. That for me was money. I mean, so how do you weigh these things?
Yeah, in calculating who is poor, statistical service take all these things into consideration. Even if you are a farmer, the farm producer you cultivate and eat yourself with are selling, they try to quantify all this and multiply by the number of people that you are taking care of to come out with this average income that determines, the income at the household level, that determines the average income at that household level. So if you put all the cattle and all the other things together and value it, and also looking at the number of people that that particular person is taking care of, and on average, how much is each individual in that household earning? That is the question.
You see, and what I'm beginning to see is if we are not careful in this country, we will end up calling everybody poor to the detriment of sustainability of the National Health Insurance Scheme. I mean, this is a bare fact we have to begin to appreciate. Because if you take 7 cedis as a minimum premium, okay, you realize that the premium today being paid is seriously not realistic. To the extent that if you are paying 7 cedis and paid any time you visit a hospital, you realize that the expenditure on you, in other words, the claims that is paid on your behalf, it's almost 40 Ghana cedis. You understand? Probably and more, depending on the conditions that you send to the hospital, as against 7 cedis. So you realize that by this standard, the National Health Insurance is likely to have a problem if this situation continues. You understand? Because if you have, by virtue of the figures I've just mentioned, you realize that there is a financing gap between these two angles, considering the two angles. 7 cedis as against 40 cedis. That is a difference of 33 cedis. So the 33 cedis is a problem, so to speak. You understand? So if we are not careful, yes, we want to get more people onto the National Health Insurance Scheme. Yes, we want to know who is pro-poor, who is poor, and who is what. But then, are we also looking at how best we can sustain this very wonderful social intervention policy? Otherwise, we will be looking at the poor, and at the end of the day, we don't have the health insurance scheme at all.
But again, following your argument there, is it also possible to begin to look at it from the broader perspective, just as all other insurance companies look at insurance, where the more accidents you have, the more premium you pay? And so the frequency of your attendance at the health service provider should determine how much you pay. Shouldn't that be the case?
You see, the case, can I take that?
Yeah, you can take that.
You see, the case here is that, you see, if you take Ghana, for instance, the people who visit the hospital the more are the very poor. Okay? So if you base the argument on the fact that the more you visit the hospital, the more premium you pay, it will lead to a situation where some people will not even go to the hospital at all. When they are sick, they will resort to these herbal concoctions and the like. And that will not be very helpful to the nation as a whole. You understand? So what I would want to suggest strongly is that we should begin to look at a realistic premium, to the extent that when you pay that premium, you should be able to have access to the healthcare service delivery from the hospitals. Because I speak for the hospitals and I know exactly what I'm talking about. You understand? So we need to have a realistic premium. I am very much aware that the President has sanctioned a review of the whole National Health Insurance Scheme. And I'm pretty sure that if things work out well, I mean, we should be looking at the premium as well. The nation should be looking at how much premium should be paid. That should be very realistic to meet the operations of the National Health Insurance Scheme. Otherwise, we should be heading towards a serious zone.
I realized you were itching to add something when I talked about the frequency.
Yes. The reason why the NHIS doesn't do that is that the health insurance program is a social protection program. So you cannot base the premium somebody pays on how frequently they visit the facilities. It's that most times it's private health insurance that do that. They assess your risk and then charge you a premium based on several factors: your age, your gender, where you live. All those things are taken into account. But the NHIS is a social protection program, so it's supposed to afford people to take away the cash and carry system that we had previously and allow them to access healthcare. And like he said, right now, sustainability is a big issue for the NHIS. And as of the end of December 2014, the NHIS has a funding gap of 333 million, around that figure. So the NHIS has an income, and the claims and other services that we have to pay for far outweigh the income that we receive. So sustainability is definitely an issue. And if you look at the people who also visit the providers, most of the providers that NHIS works with, more than 80% of the people who visit their facilities already are people who already have NHIS member. Who are already on the NHIS. So NHIS is widely patronized by the Ghanaian population. The issue of looking at the realistic premium, obviously we can't pay an actually determined premium. But after 12 years of existence of the NHIS, it probably might be time to look at it. But the other thing is that how do you do that without affecting the people who truly and absolutely cannot afford it? Yeah. So the NHIS is working with the Ministry of Gender and Social Protection to develop a point system, so that if people come in to register, or if NHIS goes out to the public to register, we will use this point system to assess the people, and depending on the answers you give, will be able to determine if you really truly are poor and cannot afford a premium, then you'll be exempted. Then the others, they would have to pay what they are required to pay.
Right. When I come back, I'll be asking both you and Frank about the impact those who have been able or are able to frequently access the services. But what has been the impact on them? Do they come back? Do they come to the hospitals and go back better persons, or some of them leave with worse conditions? Because we've had reports of ill treatment even at health centers because they were on NHIS, and there were some health service providers who say, look, if you want proper treatment, you better choose to pay. Otherwise, we'll give you NHIS and there's no real effect. But Adamu, so we are talking about pro-poor, and your research talks about it as well. But can you tell us which areas specifically did you find that there were more poor people? I mean, the poor people, the definition, were in these areas than any other area.
Yeah.
Which
obviously, it's the three northern regions. Look at Upper West, Northern region, and Upper East region.
Right, I've been to these regions, but I've also been to the central region.
Yeah, actually,
I've seen poverty at the same level as there was in the Upper West and Upper East
because
regions.
of our focus, we are basically focusing on 4 regions.
Okay.
Basically, the 3 northern regions and the Greater Accra region.
Right.
Yeah,
Okay.
if you are talking about poverty, at least the grandfather is in Upper West, the grandmother is in the Upper East. So we focus our attention in the Upper East, Northern region, and Greater Accra because of the incidence of urban poverty, which is now coming out strongly. So that is our focus. We are not actually in Western regions, so we can actually. But if you look at these 4 regions, you realize that the Upper West is leading in terms of poverty. In fact, in Wa West, almost 90% of the people there are considered as poor. Okay. Then you go to Upper East and then the Northern region. Greater Accra, we don't have so many incidents of poverty in Greater Accra region.
And did you also find out the causes or the cause of the poverty of the people in these areas?
No, we didn't actually do that. Yeah, that is not beyond the scope of the study.
Okay, but as an observer and somebody who's been working there in the center, do we know what it is that makes these people so poor?
Yeah, one has to do with climatic conditions, especially within the 3 northern regions, when people are not even sure when the rain is coming. And if they should even cultivate, sometimes they end up getting nothing. It has to do with cost of production. Most of them need fertilizer because the land they are not fertile. How do they have access to these fertilizer? The government subsidy fertilizer is not getting to them, the people on the ground. So these are the issues that keep on making the people very poor. It has to do with climatic conditions.
And before we go, I'll be asking you, definitely, I know that your report made some recommendations. Maybe you'll spend some time telling us about what those recommendations are, and we'll find out from the NHIA if they are going to consider those recommendations and how early they're going to implement some of those recommendations. But again, turning my attention to you now, what impact is the NHIS making on the people? Is it positive? Is it negative? What kind of reports do you have in your hospitals?
At the hospital level, I would say positive, because there is one important thing that we have to know as a nation. Every medical practitioner has it as a responsibility. It's obligatory that whoever visits your hospital, you are expected to ensure that the person lives better than how the person came into your facility. Now, of course, you put it right that there are instances where people come to the hospital and they begin to say that, yes, if you're not holding the health insurance card, you are not going to get this 1, 2, 3 treatment. You see, this is something we need to correct as we move along, to the extent that there are instances where you have some medicines that are not on the health insurance list. Earlier on, I mentioned that we have what you call branded product and a generic product. You understand? Now, when a clinician, after treating you, realize that, look, your condition demands that I give you a branded product, obviously you have to pay for that branded product because the National Health Insurance gives generic products. Okay? So in that respect, you are compelled to pay for that particular drug. Okay? If you are unable to pay, it is required. Sorry, it is required that the clinician, prescribe that for you to go elsewhere and then get it. You understand? So that is one aspect of it. So I would want to strongly state that when a health insurance scheme is giving out a card to the people, they should add this sort of education to it. That look, if you're going out to the hospital, it is not everything that you go there you get for free. Now, when it happens that there are things that you have to pay for, please just demand a receipt to indicate that truly you are paying for something which is not covered under the National Health Insurance Scheme. So if that is not done, it throws a whole lot of confusion into the system.
But the allegations are that sometimes the illness falls within the coverage area of the NHIA or NHIS. However, because people want to make money, and sometimes these are private hospitals, they want to make more money, and because payment from the NHIS is not forthcoming, they tell you, look, you better come this way, otherwise we cannot treat you on the NHIS.
Yeah, this actually happened some time ago. I must confess, with all sincerity, that some time ago, when you get to some of the hospitals, you realize that they were not getting money because about 80 to 90% of their total revenue comes from the National Health Insurance Scheme, and payment had not come for almost 6 to 7 months. So obviously the suppliers are also not giving medicines to the hospitals. So what do? So they tend to demand money for the drugs, not necessarily the services. So I must say that they were not demanding money for the services, but for the drugs. Because obviously you and I know that the hospital do not manufacture drugs. They also procure it from the Chamber of Pharmacy. Even as we speak now, I might say that the Chamber of Pharmacy does not give credit to the hospital beyond a certain limit any longer. Meanwhile, the National Health Insurance owe a longer period than the Chamber of Pharmacy is demanding their money. You understand? That is the situation we find ourselves in. So going forward, you will agree with me that if that situation continues, we will get to a level where the hospitals, clinics, and the maternity homes would be demanding money for the medicines. I might say not for the services.
Adwoa, how do you react to these allegations?
Those are obviously some of reports that we've had that some providers ask patients to pay for the services even when those services are covered by the NHIS. The NHIS, I think if people are not as well informed about their rights under the NHIS, those situations can easily happen. And I've even had situations where, because people know me personally, maybe they are the hospital, they've gone to seek services, and some facilities are charging them for it. So they call me and then they ask me, and then when I tell them that this is supposed to be covered, eventually the provider ends up not charging for those services. The NHIS definitely is making all efforts to educate our members as much as possible to what they are entitled to and what they are not entitled to under the NHIS. But the NHIS benefits package is very broad. It covers majority of the diseases in Ghana. Most of the things it doesn't cover are maybe cosmetic surgeries, some types of cancers, but it covers dental services, it covers maternal health services. When we talk to providers, some of the reasons they give for also charging is because some of the NHIS, they are not receiving their funds from the NHIS on time. I think the part where there might be a bridge is the fact they might inform the clients that these services are not covered, but they may be covered, rather than give the actual reason why they may be charging the patients, but they tell the patient that these services are not covered. So the NHIS also has to come in and try and rectify that these services actually are covered.
Right.
So they're not supposed to be charged.
I understand now. So, Adamu, obviously, you have identified that the very poor are not covered by the NHIS. I mean, the conclusion is that the National Health Insurance Scheme, the way it is now, is not pro-poor. Am I right?
Yeah.
So what are the recommendations you make?
Because
and then here is a copy of the report that St. Ghana has put together. Is the National Health Insurance Scheme pro-poor? That's it right here. And so the recommendations are in here.
Yes.
What are they?
Yeah, I think my friend just mentioned that one of the main challenge with NHIS identifying indigent to register is the definition, the act actually, the definition of who is poor by the act. And unfortunately for us, that particular act, Act 650, has been repealed and replaced with Act 852, which now transfers the mandate of identifying who is the poor to Department of Social Welfare, which we believe that if you transfer that mandate, then the Department of Social Welfare should be well equipped enough in terms of human resources to be able to go down to the community level to identify these people who are poor. In addition to that, we should start also looking at some influential people at the grassroots level, at the community level, such as chiefs, opinion leaders, to also help in identifying those who genuinely cannot pay for the premium, and then we register them for, we register them under the NHIS indigent category. The other thing has to do with, the question is, where are these 2.2 million people? They are there. We know them. Can the National Health Insurance, together with the Department of Social Welfare and Ghana Statistical Service, collaborate to identify these 2.2 million Ghanaians who cannot even feed themselves and register them? That would be a starting point of identifying the indigents for registration. The other thing that we did not talk about here is also the mechanisms put in place to ensure that the poor benefit from the National Health Insurance. For instance, we have the free maternal health care program for pregnant women, where pregnant women are not supposed to charge when they are identified as pregnant and they go to they are supposed to be registered free of charge. But we also realize that that program is not working as expected because it be dealt with a lot of unapproved charges. And also there's also lack of drugs.
Okay, we must be wrapping up because we are almost at.
I think I want to
disagree.
Yes,
quickly, then we can wrap up.
I want to react to the unapproved charges. See, if you are identified as a pregnant person, you get to the hospital. Definitely, you have to go through some tests. You know, at that level, you do not have the health insurance card. So whatever test that is conducted on you, you definitely have to pay. And that does not call for, that does not mean that they are charging you illegal fees. I think that is what we have to clear properly.
Is that the only condition under which people are charged fees that they consider as illegal?
No, which other one?
Yeah, some are admitted and they are taking about
even when they have
and 30 to 100 Ghana cedis without a receipt. In our focus group discussion, these issues came out strongly.
Have you heard about such reports?
Yes, we have.
People have cars and yet they are charged for services that are not on normal circumstances they shouldn't be charged for.
There's some pregnant women who goes to the facilities have a list of things that they are supposed to bring for their birth, and some they have to bring. But others may be part of the NHIS service charge, but they require some of the pregnant women to bring those to the facilities as well. But I mean, one of the issues I think he mentioned in his study was they ask pregnant women to bring detergent supposedly to clean their ward or whatever it is. But I think those are supposed to be the hospital's responsibility, not the pregnant woman who's coming to give birth.
And the food as well?
Well, the NHIS tariffs cover catering. If the hospital provides for catering, the NHIS tariffs covers.
And actually, we also did a story. I did that story where pregnant women in some hospitals were asked to buy, even not bring from the house, but you come to the hospital and you have to buy the detergents and the soap from some of the nurses
in the hospital.
In the hospital.
I mean, then that should be a secret business. Some of the nurses may be undertaking, but under normal circumstances, like she said, in the case of the food, you see, the accreditation status of the hospitals, clinics, and the maternity home determines who provide catering services. Yes. Therefore, if you are not qualified to provide catering services and a pregnant woman comes to your facility to deliver, and you ask that person to bring food along, or tea or flask or whatever it is along, I think that is legitimate and it is right. You understand? And if the person is unable to bring it and it is available that you can sell to the person, fine. I think that should be endorsed. But it is only when the hospital is mandated by law, as far as the accreditation status is concerned, to provide catering services, and they go on to demand such things. That is when we would call that one illegal.
Okay, we are out of time now. Let's wrap up. I'll start with you, Adamu. So, after this report, you've put it together. So what? What next?
Like I said, we just don't publish the report for publishing the report sake. We are going to engage district authorities on this report, as well as the national and the regional authority. We are going to engage them with the findings. We'll have the discussion at the district, the regional, and the national level to see how best we can deal with some of these issues that have been identified by the report.
And Frank, you disagree already with some of the issues he has raised. Have you read it at all?
Yes, I have.
And what do you think of it?
In fact, I'm very happy. Sen Ghana has done wonderfully well, because whenever you are carrying out a policy like this, which is a state policy, and somebody must actually go around to monitor as to whether your policy being implemented is targeting the very people that policy is supposed to look at. So therefore, I think by and large, Sen Ghana has been very wonderful in this regard. And I think that some of the recommendations are very wonderful, especially the collaboration between the Department of Social Welfare and the National Health Insurance Scheme to identify the very poor people in our society, to enable them, register them accordingly. I think that is wonderful. But then the only thing that they've not been able to stress on, that I think that they should have done for me, is to talk strongly about the premium. You know, whilst they are agitating that people should get onto the board, they should also be agitating for the low premium that the National Health Insurance is charging. That will ensure the sustainability of the National Health Insurance to enable the very poor people that we're crying for to enjoy it in perpetuity.
I'll give you the very last word. Is the National Health Insurance Scheme pro-poor? That's the question they are answering. You think they got the right answers?
Well, absolutely, they did. The NHIS is very much aware that our targeting of the poor has we have some concerns when it comes to targeting the poor. But over the past couple of years, our indigent population has moved from about 100,000 to, at the end of last year, we've covered about 1.5 million people who are considered indigent. So the NHIS is implementing various interventions to reach these people. We do some mass registrations. We go to institutions such as asylums or prisons to register the poor and the vulnerable. So we are doing all these things to be able to bring on board the people who cannot afford to pay for the health services. But there are challenges, and our collaboration with the Ministry of Gender and Social Protection is one of the ways through which we are enrolling the poor onto the NHIS. And like I said, just next week we are unveiling the point system through which we'll be able to particularly target by asking them questions. We'll know, is this person really somebody who's supposed to be exempted under the indigent category or not.
And that's all time will allow us, and I'd like to thank you, ladies and gentlemen, for educating us on this issue. Is the National Health Insurance Scheme pro-poor? I've been speaking with one lady and two gentlemen. Adwoa Twum, seated to my left, is the Senior Manager, Research, Policy Monitoring and Evaluation at the National Health Insurance Authority. She's a big woman. Thank you very much, Adwoa, for coming. I enjoyed talking to you. Frank Torblu is the Executive Director of Health Insurance Service Providers Association. And sorry for mistaking your identity much earlier. And I'm very glad that you came. Mr. Adamu Mukaila is the Program Officer at Sen Ghana, the people responsible for putting up that report together. It's a National Health Insurance Scheme pro-poor. And he believes that, no, as things stand now, the National Health Insurance Scheme is not pro-poor, and they have made recommendations as to how it can be made pro-poor. I ask you, are you poor? Well, from the definition, I definitely am not poor, and I thank God for that. Thank you very much. We'll see you again tomorrow for another edition of Moomen Tonight. Until then, you have a very good night. We'll see you. Okay. Thank you. Nice one.
Thank you,
nice one. We have to leave some space for our adverts when we are